And Dr. Janelle, this transitions perfectly segue right into our final talk for today. Dr. Janelle's getting the slides all set up. And she's going to talk to us about perinatal HIV update, perinatal prevention, things that are new in this realm.
Okay, well, I'm going to be closing us out here today with care of pregnant people with HIV. This is certainly an important topic, and it's not just care to prevent perinatal transmission, it's to also make sure that our folks who are pregnant can get the care that they need, because for many people, having children is a life goal, and we want people to live their best lives regardless of the many challenges that they may face in other avenues. I have nothing to disclose. And my objectives for today are that at the completion of this presentation, you'll be able to describe testing for HIV in people who are pregnant, to recognize risk for perinatal HIV transmission, and to develop patient-centered, team-based treatment and delivery plans to prevent perinatal HIV transmission. And I hope that everybody's gotten the subtext in each of our talks. I believe we've talked about, welcoming from the front door to the back door. Everybody makes a difference. Every single person in the clinic makes a difference. If you're the person that's, doing the billing, you make a difference. You may not have a lot of face time with patients, but what you do really matters in that patient's ability to stay in care. So without further ado, I'm going to transition, but I do want to highlight that there has been a move to change the terminology for people with HIV who are pregnant, to stop saying women who are pregnant. But in certain places, the CDC still has that, and DHHS still has that in a few places. So I try to be as careful as possible. But if you do see that, it's because it was already part of whatever slide it was in. That I copied. So we're going to start with a case. Brandy is a 32-year-old woman who presents in her fourth pregnancy with rupture of membranes at an estimated 24 weeks gestation. Unfortunately, she had no prenatal care during this pregnancy. She had a lot of things going on, including multiple moves. She's quasi-homeless and has been couch surfing and just really didn't set down roots to be able to get prenatal care before she presented. She was really intending to, but it just didn't happen for her. So she came to labor and delivery, and testing was done at admission to labor and delivery. And those tests returned with a test that was positive for gonorrhea, but negative for chlamydia and syphilis. And she had a fourth-generation antigen antibody HIV test. In our institution, that is our rapid test, because you can get the first two steps of the HIV diagnostic algorithm really is a point of care test. You can get that back within an hour. So her first step was positive. That's the antigen antibody screen. And then it went to the second step, which is that antibody differentiation assay, which tells you whether somebody has HIV-1, HIV-2, both, or it could be indeterminate. And unfortunately, that screen was negative. So you're left wondering, does this person have a false positive antigen antibody test, or is she acutely infected? And we didn't get an answer to that for a very long time, because she came at Christmas time and the viral load pended and pended and pended and didn't result for days, like 12 days. So this patient had a vaginal delivery 6 days after she presented to the hospital. No intrapartum AZT was administered. She was not started on antiretroviral therapy because the thought was that this might be a false positive test, and they hadn't gotten the last step, which is a viral load. The baby was fed formula. The mother's breast milk was expressed and stored, so she did not breastfeed. And they waited until the viral load resulted, and her viral load was 14 million. And that did result days after she presented initially to labor and delivery. And this baby acquired HIV infection that baby's going to have to live with throughout the rest of its life. So what happened? Where did this go wrong? Well, we have really a pretty good understanding about missed opportunities in caring for people with HIV who could transmit HIV to their babies. So in this particular case, the missed opportunity was that this patient had no preconception care. She became pregnant and then had no prenatal care. She did not have an HIV test like many women do early in pregnancy. She got it when she presented with ruptured membranes, and you have to deliver after that. You can't just sit on that for weeks and weeks. The baby got inadequate antiretroviral prophylaxis. There was no cesarean delivery, which is recommended when you don't know somebody's viral load. Now, in this situation, the baby did not get breast milk, which is good. And these are, some of the steps that were missing in this patient. What could have happened? Well, this patient could have gotten adequate preconception care and family planning services. She'd already been pregnant 4 times. Did she really want to have another baby? Was birth control ever discussed with her after her last delivery? We need to make sure that we have access to accessible, affordable, and welcoming prenatal care. Universal prenatal HIV testing, providing antiretroviral prophylaxis to everyone that's eligible. Using C-section delivery if the maternal viral load is not known or is greater than 1,000. And, there's just lots of services. And really, I like this last one, which is we really need comprehensive services for the person who's pregnant and their baby. That's very, very important. And we need to make sure, as Dr. Nall pointed out, we have a welcoming environment that people feel safe coming. And I'm sure that for this particular patient, she was not very excited about getting care when she knew that she was going to get kind of stigmatized for waiting so long to get into care. So there's lots of things that kind of get in the way of people getting the care that they need. I wanted to highlight this study that was done in actually Florida. It was a retrospective review of de-identified data from Florida's EHARS reporting system. And this looked at 4,337 births and 70 or 1.6% of those babies were perinatally infected. And among those who were infected, there was maternal use of street drugs, or the mother had acquired an STD during pregnancy in 1/3 of the cases. So we know street drug use, getting an STD during pregnancy is a big risk. And I just want to remind you from my STD talk, it's actually easier to get an STD in pregnancy. And we'll talk a little bit about how it's actually easier to acquire HIV if you're exposed during pregnancy as well. So what were factors that were associated with perinatal transmission of HIV in this study? Well, it was late diagnosis. The mother had acute HIV infection because remember, during acute HIV infection, the viral load is very high. There's no antibody yet to even drive that viral load down. We know antibody's not going to make that viral load go away, but at least it might lower it. So in acute infection, it's very likely that people will transmit HIV perinatally, and then poor or late prenatal care. So this is a very important thing to think about. And when we think about taking care of people who have the potential to be pregnant, really the southern United States has a tremendous number of folks that are in this age range and have HIV, and each and every one of us need to be thinking about, what does this person want to do for family planning? Are they ready to have a baby? Is their viral load suppressed? There's a lot of steps that need to go into taking care of people that have the potential to get pregnant, not only to protect their own health, but to protect the health of their unborn children. So I did want to highlight these disparities that we've been talking about kind of all day. Most perinatal HIV diagnoses were among Black and African American children, and you can see this in this infographic from the CDC. 65% were born to Black or African American people, 14% to white, 9% to Hispanic Latino. So we really have to focus on, gosh, what's happening? How are we not getting people who are Black and African American into care? Is it because we don't have providers that look like their patients? Do we not have a welcoming environment? Do we have barriers to access? Is there a cultural issue that is preventing people from accessing healthcare? Because we really need to do a better job of this. I want to highlight that HIV can be transmitted anytime during pregnancy. It can be transmitted after conception, during vaginal childbirth, and through breastfeeding. And remember that there's about a 25% risk of HIV transmission in pregnancy without any intervention. So we need to think about catching people early. But there's a less than 1% risk if we give suppressive antiretroviral therapy throughout pregnancy, if we give postnatal, that's after birth, infant antiretroviral prophylaxis, if we do a C-section and give IV AZT if that's indicated, and if we counsel folks to avoid breastfeeding. Even today, it appears that in people that have a suppressed HIV viral load, there is still a risk of HIV transmission through breastfeeding because it's a slightly different reservoir than the bloodstream, which we can measure. So we can measure people's viral loads in the blood and know that they're not going to transmit their HIV sexually. But in terms of breastfeeding, the data suggests that having a suppressed blood viral load may not be enough. So it really needs to be a case-by-case discussion about breastfeeding with people that have HIV infection and are having a baby. I want to highlight that for many decades, we've known the viral load during pregnancy is the strongest predictive factor for transmission. So if we can treat people throughout their pregnancy and maintain a suppressed viral load, that really does reduce the risk of HIV transmission. And I want to highlight that we have done a really good job over the years. But I think many people would argue that any baby born with HIV infection is one too many, and we could do better. And so, we actively want to try and address this with each and every one of our patients that has the potential to become pregnant. The CDC goal is less than 1 per 100,000 live births and less than 1% of HIV transmission to babies. So this is a really big goal, but we're getting closer, and making sure that folks are diagnosed with HIV infection is a big part of it. So that gets me to my first polling question, and I think it's my only one, so you can snooze after this if you want to. When should pregnant women be screened for HIV? Should they be screened at entry into care for pregnancy, anytime they have signs or symptoms suggestive of acute HIV, in the third trimester if they're at risk for HIV acquisition, or all of the above? Okay, I've got 1D in the chat box. Anybody else want to vote in the poll? I am not seeing any votes at all. So hopefully you guys already, oh, there we go. I couldn't see it. Sorry, guys. 88%, you guys rock. It is all of the above. So the correct answer is testing at entry into care for pregnancy, anytime someone who's pregnant has signs or symptoms of acute HIV, and definitely in the third trimester if at risk for HIV acquisition, because we may not recognize somebody who acquires HIV throughout their pregnancy. So thank you guys for participating. For some reason, I couldn't see you doing that. So screening for HIV is really, really critical if we're going to prevent transmission of HIV during pregnancy. I see a comment in the chat, and we'll get to that. So for people who are pregnant, we want to screen at presentation for pregnancy care, repeat in the third trimester. So we ideally would do that at less than 36 weeks of gestation, because we need to make a delivery plan if somebody has unrecognized HIV infection. And then We want to make sure we're screening if somebody's at risk of acquiring HIV during pregnancy. Those may be people that live in an area or hospital with a high number of people with HIV, folks that engage in transactional sex, that is, sex being exchanged for drugs, money, or housing, people who have drug use, or they have a sex partner with HIV, or a new sex partner or more than one sex partner during their pregnancy, or suspected or diagnosed sexually transmitted infection. These are all really important markers, and I will just argue that for the vast majority of us here in Florida, we are in areas that have a high number of people with HIV, so it would be prudent to repeat in the third trimester, and that is actually in the Florida law, so we'll go over that. We want to screen at labor and delivery if the HIV status is unknown and where it's mandated by law. Now, for labor and delivery testing, you want to use an expedited or rapid test so that you can get those results right away. And the goal is to have the results in 1 hour. You don't have to do the fourth generation test if that's not the test that you have that will give you a rapid result. You can use a third generation, like point of care test, if that's what you need to. In that situation, you might miss people that have acute HIV. So you'll want to make sure you do a good symptom screen. And these are needed if there's prior negative HIV test, but the mother's at high risk for HIV infection, ongoing street drug use, new STD diagnoses during pregnancy, sex partners with HIV infection, all the things that we talked about before. And so the CDC and DHHS recommend these first ones that I talked about. And here at UF, we actually do this also for teenage mothers because we recognize that many of them have risk-taking behaviors that they may not disclose in a history. And so we try and do rapid testing for teenage mothers as well if they present later in pregnancy. So what are the testing laws by state? Well, Florida has statutes for HIV testing during the third trimester, but it's not specific for newborns. So in many states, they just test the newborn babies, like New York, for example, the yellow ones. They don't necessarily have statutes for testing in the third trimester for the mother. So you can see that there's a kind of a disparity or difference, I guess, in the state laws. This is not uniform throughout all the states. So if you leave Florida, make sure you know what the law is in the state that you go to provide care. And I wanted to highlight the state law that recommends testing at initial or mandates testing at initial examination related to the current pregnancy, and again at 28 to 32 weeks of gestation. And we want to make sure that if somebody has known HIV infection, we don't have to retest them, and we want to record any declinations of testing in the medical record. So when we think about women who are pregnant that don't already have HIV infection, we need to worry about whether they might acquire it during their pregnancy and remind them that even though they're already pregnant, they may not need to use condoms to prevent pregnancy. They will want to use condoms to prevent acquisition of HIV if they have multiple sex partners or new sex partners that they don't know their HIV history. So if you look at this table, you can see this is a study looking at people that practice condomless sex and acquisition of pregnancy, of HIV in pregnancy. And it was late pregnancy and the postpartum period that were the most high risk points. So we worry about testing during pregnancy, including late pregnancy, but we also need to think about that postpartum period because there are changes, physiologic changes that increase the risk of HIV acquisition postpartum. So if somebody comes in with acute HIV symptoms postpartum, even though you just tested them maybe 2 months ago for HIV, you may need to retest them again and make sure you add that viral load there to the test. So screening for HIV, we want to make sure we not only do the lab test, but we look for signs and symptoms of acute HIV infection. If those are present, as documented in this picture, we want to make sure that we not only get an antigen antibody assay, but we check a fourth generation or check an HIV viral load as well. And partners of all pregnant people should be referred for HIV testing when their status is unknown. So I have to say we have a lot of people who are pregnant and come to get care. They're known to have HIV, but the HIV status of their partners isn't known. And we really should encourage their partners to also get tested. And I talked a little bit about the HIV testing algorithm, and you may have been like, what is she talking about? So the current fourth generation testing algorithm has 3 steps. It starts off with an antigen antibody combination immunoassay. So that's looking at early markers of HIV infection, the P24 antigen, as well as the presence of antibody, which is present later in infection. And that first screen doesn't tell you which part is present. It just says one of those 2 is positive. So then you have to go through an HIV-1, HIV-2 antibody differentiation immunoassay if that first screen is positive to determine whether they have HIV-1 or HIV-2. There's 2 different types of HIV infection that you can get, with HIV-1 being most common here. But if it's an indeterminate test or it's negative in the second step, then they need to get an HIV NAT or an HIV viral load or qualitative HIV RNA test. So there's multiple steps. And if the first step is positive, the second step is positive, that person is diagnosed with HIV. If the first step is positive, the second step is negative, you go to a viral load. If that's negative, that means that that first step was a false positive. If it's positive, that means that person has acute HIV infection, and our patient had a positive first step, a negative second step, and a positive third step. So she definitely had acute HIV infection, and her viral load backed that up. It was extremely high. So that is how that testing algorithm works. And what should happen if you have a pregnant person presenting and they have a test that is indeterminate, you should start treatment for HIV infection and continue through testing until you know for sure that that person either has HIV infection or doesn't. But meanwhile, they should get antiretroviral therapy to prevent transmission to the baby. And if they're right at delivery and you don't have this information, it's recommended to discuss a C-section because you don't know their viral load. And if they have acute HIV infection, it's going to be likely very high. And you're going to want to give intravenous AZT. I want to highlight that if that test is negative, but you know that somebody may be at risk for acquiring HIV infection, it is totally appropriate to talk about HIV pre-exposure prophylaxis for people who are pregnant. HIV pre-exposure prophylaxis that's appropriate for people that can get pregnant is just Truvada. Remember that people who have receptive sex with a vagina do not there's not sufficient data about the efficacy of Dovato, and there's no data about the efficacy of or the use of cabotegravir for PrEP in someone who is pregnant. So while cabotegravir seems to be very effective in women, we would not give it to somebody who is pregnant because there's no data on safety in pregnancy. So really the only thing for someone who has HIV and is pregnant is Truvada at this point. So I just wanted to highlight that it is safe in pregnancy, it's safe for somebody that's breastfeeding, and it may prevent them from getting HIV infections. So don't hesitate to bring that up. So what do you do to care for somebody who is pregnant and has HIV infection? Well, I will say I really am happy with some of the updates that have been made to the Department of Health and Human Services guidelines. This is new updates that were made in December of 2021, and over time, these guidelines have gotten more inclusive in their language and have actually done, I think, a better job of giving good direction for how to care for our folks. So we want to start antiretroviral therapy as soon as possible, regardless of the HIV RNA level or their CD4 count, even prior to the result of the genotype. And this is for the health of the mother and the baby and to prevent perinatal HIV transmission and secondary sexual transmission to their partners. Early viral suppression is associated with a reduced risk of transmission to the fetus. And, you can start this, you can modify it later if it doesn't agree with the pregnant person, if they're having trouble tolerating the medication, you can always modify it. And if you find out that somebody that you started therapy on is not actually infected with HIV, you can always stop it. But the goal is to maintain an HIV viral load level below the limit of detection during pregnancy and postpartum and throughout life. And just realize that this is really a lifelong process for the vast majority of people. And remember, antiretroviral therapy is providing pre-exposure prophylaxis to the fetus. So you're treating the baby while you're treating the person who's pregnant. So how do we know it really matters when you start antiretroviral therapy? Well, there was a fabulous study that was done. It's called the French perinatal cohort. And in 2015, they published a longitudinal study that had been going on from 2000 to 2011, looking at 8,075 mother-infant pairs. And in this study, mothers received antiretroviral therapy. They delivered live-born children. The HIV status of the children was known, and they did not breastfeed. But they didn't all start antiretroviral therapy at the same time. The overall rate of perinatal transmission was 0.7%, which is really low. 2,651 children born to women on antiretroviral therapy prior to conception, who got antiretroviral therapy throughout their pregnancy, who maintained a suppressed viral load less than 50 at delivery, had no cases of HIV transmission. Regardless of the viral load at birth, the risk of transmission varied based on when antiretroviral therapy was started. So if it was started prior to conception, the risk was very, very low, 0.2%. If it was started in the first trimester, it was just a little higher, 0.4%. If it was started in the second trimester, it was even higher, 0.9%. And if it was started in the third trimester, it was at the highest, 2.2%. So we know we need to diagnose people early. We need to get them on therapy right away. It could make a difference, not only for the health of the pregnant person, but definitely for the health of their baby. And this was a statistically significant difference, suggesting that it really is scientifically proven to make a difference when antiretroviral therapy is started in pregnancy. We want to start it ideally prior to conception. I want to highlight that medications in pregnancy are not always easy. Many physical changes happen that affect drug pharmacokinetics. You have a decrease in seroproteins, increase in plasma volume. I see some of the best filtration rates in my pregnant people. Their kidney filtration rate just can be amazing. And then they will also have problems with delayed stomach emptying. So nausea can happen, a lot of issues can happen. And so therefore, we may have to change how we give antiretroviral therapy. So for some people, we may have to give higher doses of antiretroviral therapy or more pills to make sure they get adequate blood and placental levels. What are the medications that are currently preferred for people that are new to HIV during their pregnancy? Well, we want to give 2 nucleoside reverse transcriptase inhibitors and an integrase inhibitor or a boosted protease inhibitor. The preferred backbone nucleoside reverse transcriptase inhibitors are a combination of abacavir and lamivudine. You can use that. The combination tablet is called Epsicom. They have to be HLA B5701 negative. And if you're going to use atazanavir or efavirenz for this pregnancy, you can't do that if the viral load's over 100,000. So this would not be a rapid start choice for somebody who's pregnant and you're just ready to start drugs right then. You could also use tenofovir alafenamide with emtricitabine, that's Descovy, tenofovir alafenamide plus lamivudine, tenofovir disoproxyl fumarate plus emtricitabine, which is Truvada, or you can use these combination tablets of TDF and 3TC. But I did want to highlight a change in the most recent update of the guidelines is that Descovy is now preferred, or tenofovir alafenamide is now preferred in pregnancy. So that's a great change. The preferred integrase inhibitors are dolutegravir or raltegravir. Dolutegravir has a benefit of once daily dosing. It also has a higher genetic barrier to resistance than raltegravir. One thing that you do need to think about is that you need to make sure you're avoiding drug interactions. Dr. Irvin was talking about this earlier. Dolutegravir does interact with calcium or iron, and so you will need to either dose separate or give food recommendations to avoid those interactions. And then raltegravir is a preferred drug, but it has to be dosed twice daily in pregnancy. And I think a lot of people don't want to have to take a pill twice daily in pregnancy. The HD once daily formulation has not been studied in pregnancy, so you don't want to use that. It is well tolerated and has few drug interactions. And interestingly, raltegravir doesn't have an interaction with calcium if you're using the twice daily regimen. So that might be a good option for some of your patients that can't really, get the dolutegravir dosing right with calcium. The preferred protease inhibitors are boosted darunavir or atazanavir. If you're going to use boosted darunavir, you do have to use a twice daily dose. So that's going to be darunavir 600 milligrams with ritonavir 100 milligrams twice daily with food. Atazanavir is a once daily dose. So 300 milligrams once a day with ritonavir once a day with food. Some people would increase that dose of atazanavir to 400 milligrams in the second and third trimester, but not everybody does, and it's not, insisted on the guidelines. But just remember that atazanavir will cause maternal hyperbilirubinemia. It doesn't really increase the risk of neonatal problems related to bilirubin. Atazanavir does have that added little challenge of having interactions with acid-reducing agents, so something to definitely keep in mind. There are some alternative antiretroviral medications in pregnancy. Back in the day, we always started zidovudine because there was the best data on the use of zidovudine early in the HIV epidemic, and so we'd give Combivir all the time. But that is definitely an alternative because it does cause some side effects in pregnancy, including nausea and anemia. The preferred non-nuclear or the alternative non-nucleoside reverse transcriptase inhibitors are efavirenz and rilpivirine. Remember that rilpivirine has to be taken with food. It interacts with acid-reducing agents. There are issues if the viral load is above 100,000 or the CD4 count is less than 200 because people can actually not get control of their HIV very well if you use it in that situation. And PK data suggests that there are low drug levels and risk for viral rebound in the second and third trimester. So if you're going to use rilpivirine in pregnancy, I've had patients absolutely refuse to come off of a rilpivirine containing regimen. We just monitor those patients more closely, which is a reasonable thing to do if someone's already on it and they really want to stay on it. What about acute HIV in pregnancy? The preferred regimen in that situation is dolutegravir plus one of the two forms of tenofovir plus emtricitabine or lamivudine, or boosted darunavir plus tenofovir or emtricitabine or lamivudine. Many people feel if you're taking care of somebody later in pregnancy, you really need to include an integrase inhibitor like dolutegravir because it rapidly lowers the HIV viral load. And so you may be able to suppress the viral load before delivery in those situations. I want to highlight, we have so many people on this regimen, which is bictegravir, tenofovir alafenamide, and emtricitabine or Biktarvy, but that has limited data on the use of bictegravir in pregnancy, so it is not currently recommended. We also have some people that have switched to doravirine, thinking that might have less issues with weight gain, but there's no data on the use of doravirine in pregnancy. Ibaluzumab, there's no data on the use of ibaluzumab in pregnancy. So really, those should be avoided. Other antiretrovirals that are not recommended in pregnancy include cobikistat, containing regimens, long-acting injectable cabotegravir rilpivirine because there's limited data. You can't get stavudine and didanosine anymore. If you are practicing somewhere where those are available, maybe not here in the States, that is not recommended in pregnancy based on our DHHS guidelines because there are adverse events that can occur in pregnancy. Fosamprenavir, indinavir, nalfenavir, ritonavir, saquinavir, toprenavir, all of those are kind of unusual. In the ritonavir, I'm talking about as a sole PI, so that old 600 milligram twice a day regimen. And I bring this up because I did actually get a patient not too long ago that was treated by someone that was still getting that treatment dose of ritonavir. The first person I've seen in decades on that. Realize that 2-drug antiretroviral regimens, so the dolutegravir lamivudine combination drug Dovato is not recommended in pregnancy at this time. So I wanted to highlight that. And then a 3-drug NRTI regimen like a Triumec or Trizavir is not recommended in pregnancy either. Things that are not recommended except for in special circumstances are etravirine, fostemsavir, boosted lopinavir, which is Kaletra, Maraviroc, nevirapine, or T20. And I want to highlight that we do have evidence of one of the drugs that we had given warnings about a couple of years ago, maybe being the best regimen to use in pregnancy. So this Impact 2010 study was presented at CROI in 2020, and it suggested that dolutegravir plus tenofovir and alafenamide and emtricitabine is associated with the fewest adverse pregnancy outcomes when started in pregnancy. And that is compared to an efavirenz containing regimen. There were fewer cases of preterm delivery, which we know is a risk for folks that are taking boosted protease inhibitors. There's decreased risk of small for gestational age. Hang on, let me move this picture. And a decreased risk of stillbirth. So there was a slightly increased risk of preterm delivery in our efavirenz containing regimen, an increased risk of small for gestational age in the TDF containing regimen here, as well as stillbirth. So it looks like the TAF containing regimen combined with dolutegravir may be the safest in pregnancy. So I wanted to highlight some key points. In most cases, people who present for obstetric care on fully suppressive HIV therapy already, so they've already been diagnosed, they're coming to you for care, they usually should be continued on their current regimen. But there are some caveats. You want to make sure that there is sufficient data to suggest appropriate drug exposure, efficacy, and safety. And unfortunately, there are often incomplete data on safety of HIV drugs in pregnancy. So I personally really love this table 5 in the DHHS guidelines. It's really pretty helpful, and it goes through different components and tells you whether they should be used in people that are antiretroviral naive, for people who become pregnant on a fully suppressed regimen, what should you do about continuing? What should you do about people that have gotten drugs in the past and are restarting therapy? What should you do about people that are on a regimen, but they're really not tolerating it very well, and or it's not fully suppressive? And then what should you do for people that are trying to conceive or get pregnant? So I think that this is a super helpful table, and I'll just highlight that for bictegravir, which is in Biktarvy, there's insufficient data. So if you know somebody's planning on getting pregnant and they're on Biktarvy, you may want to talk to them about switching to a regimen that has more safety data in pregnancy. But realize that this data comes from somewhere, and some people may say, I want to do it anyway. You can monitor me all day long. I'll come in and give blood. And you may say, okay, but make sure you report them to the antiretroviral pregnancy registry. That's really where we get a lot of our information about the safety of antiretrovirals in pregnancy. So I want to highlight some of the important conversations that we need to have with folks that we're caring for that are pregnant and have HIV. Really, we want to highlight the importance of lifelong antiretroviral therapy before, during, and after the pregnancy. We want to talk about the risks and benefits of antiretroviral therapy for both the person who's pregnant and the infant. And I will highlight that Appendix C in the perinatal guidelines has a great counseling guide. We want to talk about what they're going to do about infant feeding, what's going to happen after the baby's born. That baby's going to need to get antiretroviral prophylaxis. We want to talk about the fact that breastfeeding and pre-mastication of food, which is chewing food and giving that chewed food to the baby, so that food's been in someone's mouth and is given to the baby, that is not recommended. We actually have had documented HIV transmissions from folks that had HIV infection, pre-masticated food, and then gave it to a baby, and that baby acquired HIV, not in utero, but from that pre-masticated food. So that's definitely something that you should have a conversation with, because we certainly don't know everything that people do. And having that conversation kind of gives the opportunity to learn about what folks might do after the baby's born. And then we want to talk about the timing of infant diagnostic testing. And so I see a question in the chat box about this specific thing. What is the recommended testing for HIV exposed babies to rule out HIV up to 18 months of age? And how do we express getting those labs completed by providers? If you could solve some of these challenges, Daryl, that would be fabulous. Yes, testing is recommended up to 18 months of age, and there's different time points. I am not going to be talking a whole lot about perinatal management or the management of HIV infection in babies. We are going to be having another symposium in Pensacola coming up soon, and we will have one of our pediatric nurse practitioners that's very knowledgeable about that speaking there. So Taryn, maybe we can invite folks from this group to participate too if they're interested. But how do we get these labs completed by providers? You know, there's really an expectation that that's going to happen. And typically babies that are exposed to HIV in utero should be getting care from providers that, pediatric providers that are aware of this, that the babies need to be tested and will, follow through with making sure things get tested. You know, you certainly don't want to have to go so far as to, report to Department of Children and Services. But I know that sometimes that is what has to be done to get the mothers or the families of these exposed babies to get their babies tested. So there's lots of different things that we can do, but really just setting the expectation ahead of time that this needs to be done is really a step in the right direction. Explaining to people before the baby even comes how this will all work is really critical. And what we do here at UF is try and arrange for a consultation with PEDS ID before the baby even comes, so that those expectations are set, and that everybody is on the same page about how that will be done. And I think that really, really helps, because when you're trying to do it after the baby's born and there's family around, and it just becomes very complicated. So definitely, if you have the opportunity to do it ahead of time, that's what should be done. Now, it's very important to have these family planning conversations. What does this person who just, is about to have a baby want to do? It is recommended that people space babies out. It's better for the health of the person that's pregnant not to get pregnant again before a year is out. So what can we do to help them avoid another pregnancy if that's what they desire? Well, women with HIV can use all available contraceptive methods, including hormonal contraceptions. We just have to think about, will it interact with their HIV medications? There's fabulous tables in the Department of Health and Human Services guidelines. Table 3 is the one that I'm showing right here, that tells you about interactions with antiretrovirals and between antiretrovirals and some of the hormones for pregnancy. And really, just so you know that there's really no significant interactions with our currently most commonly used drugs, which are the integrase inhibitors. But if folks are on protease inhibitors or have a regimen that's boosted with cobicostat, you really do have to be very attentive to this. And I mentioned the antiretroviral pregnancy registry. This is a registry that anyone who is pregnant or anyone who's caring for somebody that's pregnant can enroll in and let the pregnancy registry know what antiretrovirals that patient was on and whether there were any adverse birth outcomes associated with that regimen. And they really do look at this very, very carefully. We do report to this registry here at UF, and they email back with questions. I mean, they really, really look at each and every individual exposure very, very carefully. And then that information goes back to the guidelines committee and changes the perinatal guidelines. So you've started somebody on antiretroviral therapy. What are you going to do to take care of them? Well, you're going to monitor their HIV viral load, and you're going to look at that viral load at the initial visit, 2 to 4 weeks after starting or changing antiretroviral therapy, monthly until the HIV viral load is below the limit of detection of the test, every 3 months during pregnancy, and then again at 34 to 36 weeks gestation to inform those delivery decisions. And some people test more frequently towards the end of pregnancy. We've definitely had women who've gone all the way through their pregnancy and then just stop taking their meds for reasons that they can't even really explain right before delivery, and then they deliver a positive baby. So really keeping a close eye, talking about how they're doing, checking in frequently. I think that would really make a difference. And it doesn't always have to be the provider checking in. We have fabulous other people. I saw Cherise Lawson. She's our perinatal coordinator here in Alachua County. She checks in. She knows who's taking their meds, or at least, as best as anybody can tell. We want to do antiretroviral resistance testing prior to starting antiretroviral therapy if never on treatment. But remember, you don't want to delay treatment. So just like we do test and treat for, people that aren't pregnant, that are newly diagnosed or returning to care, we can do test and treat for pregnant people as well. And what we want to start is, a dolutegravir or a boosted darunavir containing regimen. And then we want to do antiretroviral testing again if somebody doesn't suppress their HIV viral load after treatment. When folks don't suppress their HIV viral load, we really do need to think about drug adherence, tolerability. If somebody is feeling terrible every day when they take their meds, they're just not going to take them. We need to think about switching their meds. We want to make sure that folks that need to take their medications with food are doing that. And if it's just really too hard, or they're failing their regimen, we may have to consider changing that therapy, and that's okay. We have lots of other regimens to go with. And, don't ever make it feel like this is the last possible thing unless it really is the last possible regimen they could be on. I mean, we have some people that have a lot of drug resistance, and usually that's our perinatally infected adults, are people that have been positive their whole lives. Those are the folks that tend to these days have a lot of drug resistance. So preventing perinatal transmission to their babies is even more important, because they really know what it's like to live with HIV their whole lives. So reminders about adherence to antiretroviral therapy, labs and appointments. It's ideal if we can get those OB and HIV care appointments in the same place at the same time if possible. So really all of this coordination is critical to the success in preventing transmission of HIV infection. We talked a couple of times about what happens if there's a high viral load near delivery. If the viral load is greater than 100 or greater than 1,000, or you don't know the viral load, then these folks should have a scheduled cesarean section at 38 weeks. And you should give IV AZT, and that is an infusion. It's not just the pills. You're going to give an infusion prior to delivery. And some providers would actually give this IV AZT if the last viral load was over 50, or there were any concerns for non-adherence around the time of delivery. It really is not a high-risk medication for the baby. You can give that with relative feelings of safety. And we talked a lot about supporting people, and I want to highlight, we want to support pregnant people with HIV therapy so they stay in care and on therapy now and forever, because we want them to be at their kids' graduation from high school and college and see, their first grandkids. So talking about lifelong therapy is important, coordinating services with all the different folks that can help: prenatal care providers, primary and HIV specialty care providers, mental health and substance use disorder treatment providers if that's needed. We want to recognize that people are victims of intimate partner violence and give them support. There's lots of public assistance programs like WIC. Get them set up. And remember that your perinatal coordinator, case manager, peers, and support groups, they may be more important than anybody in this care team. And encouraging your patients to link and stay with their support system is so, so critical. involve their support system outside of healthcare if they allow the father of the baby or their current partner, family, friends. Be available and answer questions and give hope. It's a very lonely place sometimes for some of our folks that are going through pregnancies with HIV. If they, feel like they can't include the important people in their lives in every conversation because somebody might bring up their HIV status. So encourage them to disclose to the most important people, so that they're going to feel comfortable, in labor and delivery and in the postpartum unit. Nobody wants to have an accident by disclosing somebody's status inadvertently, assuming that the father of the baby knows. Maybe they don't. So understand where they are in terms of their disclosure before you have those conversations in front of anybody else in the room. And I know we think about it all the time. It's a little bit easier to think about in clinics than it is in the hospital, for sure, when that baby's there and you're running in and all excited. So just keep in mind that not everybody has disclosed to the important people in their lives that they have HIV. Always remember that fourth trimester. I've talked a couple of times about how people can acquire HIV postpartum, and it's a higher risk than for people that are not postpartum. So think about that fourth trimester as an important place. And some people call this, that fourth trimester. It's a 12 weeks postpartum, and you want to address the following: the mood and emotional well-being. Gosh, it can be really hard to have a baby. And sometimes you feel like people aren't supporting you. So address that. People can get very depressed. Address infant care and feeding, provide support. Ask about sleep, fatigue, and physical recovery from birth. If they need help, see if there's any way, to get family members to step in and help out. Talk about sexuality, contraception, and birth spacing. Try and get that chronic disease management and coordination of care with the primary care provider. Talk about health maintenance. I know a lot of people just totally don't take care of themselves after they have the baby because they're so focused on that baby, but you got to take care of yourself too. And just realize that women living with HIV are often lost to follow-up during this time period. They'll get that baby to every pediatrician appointment, but they may not go to theirs. And this just highlights this. This is from Atlanta, looking at their care continuum postpartum. And look at this terrible virologic suppression rate at 2 years, 30%. We definitely have to do better than that. We definitely need to wrap our arms around these moms and help them to stay in care and engaged in care. And that cross-disciplinary approach really makes a difference. So in summary, we want to recognize HIV infection in people who are pregnant. It's really critical for the protection of the pregnant person's health, as well as to prevent transmission to the baby. Viral load testing during pregnancy is important, and the viral load is the best predictor of HIV transmission. There's multiple effective, safe, and well-tolerated options for antiretroviral treatment during pregnancy. We're so lucky to be living in a time where there's many, many, many options. Support people before, throughout, and after pregnancy. It's really critical for their lives and the lives of their babies. And I'm going to end right here with some resources. I hope you'll take a screenshot or look at my slides later. The National HIV Curriculum is a wonderful resource for learning about HIV, and there is a section on special populations, including perinatal care and care of an HIV-exposed baby. The perinatal guidelines are fabulous. They have really gotten better over the years, and you can quickly look through those tables if you don't have a lot of time to actually read the text. And then remember that the National Clinician Consultation Center is here to help you, and they're available 24 hours a day, 7 days a week. If you are in a situation where you're caring for somebody who has HIV and is pregnant and you don't know what to do, and it's 2 o'clock in the morning on a Saturday morning, you call them and they will help you. And I have called them before myself with questions about care for women and people with HIV who are pregnant, and they've always been very helpful. So don't hesitate to reach out to them for help. And you can certainly always reach out to me or our entire AETC faculty team, and also any of the faculty in the Southeast AETC. So I will end there. And I know I've gone all the way to the end of the conference, but if there's any questions, I'd be happy to address them.